Good morning, everyone. Welcome to today's episode of the Healthcare Regulatory Roundup Compliance webinar series. Today's topic is Washington Updates, Deregulation-o-Rama. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments. Any questions posed during the webinar will be responded to via email after the webinar. We have posted a PDF copy of the presentation slides for your reference in the Resources pane. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Jennifer. Good morning, everyone. We've been hosting this Healthcare Regulatory Roundup webinar series since 2021. And roughly twice a month, we get together and we talk about how to comply with new regulations or new guidance that have been issued by the federal healthcare regulatory agencies. And this time, we're going to take a very different approach because we're going to talk about deregulation. Regulatory requirements going away and easing your administrative burden, or at least that is the plan.
What would we talk about if they went away?
I'm sure they're not all going to go away,
Okay,
Kathy.
thank you.
as we're going to discuss. But really, this movement towards deregulation falls into two buckets. There is the repeal of what are referred to as unlawful regulations, those where the agency has promulgated a rule that goes beyond its legislative authority, and efforts to repeal those types of regulations. The second bucket are burdensome regulations where there's not enough benefit to be gained from imposing a particular regulation, and how do we repeal that? So, bucket one, it's not lawful. Bucket two, it's not logical to be imposing such a requirement. So we're going to talk about both. And then we're going to wrap up with the discussion on the current status of the budget reconciliation process that as it gears back up, as Congress is now back from its Easter recess, and where we stand and where we think we are going. So let's get started with the efforts to repeal unlawful regulations by the Trump administration. And this story starts at the end of January with Executive Order 14192, Unleashing Prosperity Through Deregulation. This was the directive from the president to the executive agencies that whenever an agency proposes through notice and comment a new regulation, or it promulgates new guidance that has a financial impact on the regulated entities, the agency is now responsible for identifying at least 10 existing regulations to be repealed. So it's going, previously, if we recall, during Trump administration 1, we had an executive order that required the repeal of 2 regulations for any new regulations. So we're going from a 1-to-2 ratio to a 1-to-10 ratio under this new executive order. The executive order also directed that any new incremental costs associated with such regulatory action, to the extent permitted by law, must be offset by the elimination of existing costs that are associated with the 10 prior regulations. So it's not enough just to say, well, here are 10 regulations that we want to repeal. Those 10 regulations must have a financial impact, again, on the regulated entities that outweigh the estimated financial impact of the new proposed regulatory action. Finally, the executive order directed agencies to provide their best approximation of the total costs and savings associated with each of the new regulations and each of the repealed regulations, which of course is consistent with Administrative Procedure Act requirements as well. So there we stood on January 31st with those new instructions, with promises in the executive order that the Office of Management and Budget would be publishing further guidance for the agencies on the implementation of the executive order. And that guidance appeared on March 26th in a series of FAQs issued by OMB, and defined terms such as what is an agency, what is a regulatory action, and the like. And here we got very specific directions for the balance of federal fiscal year 2025. That in fact, any agency that intended to take any regulatory action that had a associated financial burden would need to be identifying 10 existing regulatory actions that would offset that new regulation. And again, the responsibility on the agency to ensure that the total incremental cost of regulatory and deregulatory actions would be significantly less than zero by the end of the fiscal year. And then noting that, of course, there are, in some instances, regulations that an agency is required by law to issue. And in those circumstances, it would be permissible for the agency to proceed with such action if it could not, by the time of publishing those regulations, actually identify the offsetting number of regulations and dollars for the regulations. And that the example here would be the mandated Medicare payment rules that CMS issues on an annual basis. It did note, however, that the agency should still make best efforts and act as soon as possible, as soon as practical, to take those sort of counterweight deregulatory actions to offset those costs.
Martie, the outpatient rule, the physician rule like that are currently at the Office of Management and Budget. No idea what's in them or when they will actually be released. But isn't it even possible that in those rules, they are proposing to eliminate some current requirements on hospitals?
I think they're going to use
they came up with.
Yeah, I think they're going to use any vehicle that they think they can start to drive down the road of deregulation. And if that is the payment rules, so be it. But I think, Kathy, that also raises this question. If you've got this 10 for 1 rule going,
right,
which is challenging, right? And it's also not exactly clear from the OMB guidance what counts as a rule or a regulation,
right?
Is it per sentence? Is it per page? Is it is it per Federal Register notice? And so there's this. I think some of these agencies are going to be, the opportunity to load up a regulation, shall we say? If you get one bite of the apple, make sure you're biting off 90% of the apple, right?
In other words, the rule could have things that absolutely do not apply to it that are new requirements on us. And at the same time, it could have the elimination of some requirements.
Right. I think it's just going to make
reading
make for more
fun.
make for interesting reading of our friend at the Federal Register. So, but this sort of sets our starting point for this movement towards deregulation is this January 31st executive order. And I think very clear directives from OMB that we're serious about this. There was never a similar type of direct guidance when we had the 2 for 1 rule during the first Trump administration. So this is much more providing that specific guidance to the agency and expectation to the agencies that by the end of the fiscal year, you're not going to be just at zero in terms of regulatory costs. You're going to be below zero. So you're not going to add to the burden. You are affirmatively expected to bring the burden down. So let's fast forward to February 19th. We have another executive order, 14219. This was the order directing agency heads in coordination with DOJ and OMB to review all of their regulations and thus create a list of regulations under their jurisdiction that fell into one of these specific categories, all the way from unconstitutional, or I love this, constitutionally difficult, Unlawful delegations of power, unclear statutory authority that supports a particular regulatory provision, harmful to the national interest, such as impeding technological innovation, restricting competition, resulting in inflationary pressures, as well as imposing undue burden on small and private businesses. And those lists were to be created within 60 days. And then the agencies were to consult with the Office of Information and Regulatory Affairs to create a unified regulatory agenda directing towards rescission or modification of the identified regulations. The URA is a document that I don't think it's a reliable narrator, Kathy, is that we've had items on the URA before, and you're like, really? You're going to do that?
Well, but it has target dates, and, they were in the past.
Yeah, exactly. It has not been the best calendar on which to rely in expecting certain regulatory action. I think this is definitely, this executive order was intended to, in fact, put some teeth behind the URA so that, in fact, the industry was aware of what's coming, what's going. We're still within the 60, we're just coming out. We're very near the end of the 60 days here now. Yeah, but February always confuses me because it's a short month, but we're nearing the requirement of this executive order, but yet to see any action on the URA specifically with regard to this. So something definitely worth watching. The other component of this executive order was a directive to agencies to deprioritize enforcing regulations that they believe are beyond the, quote, best read of the authorizing statute, or in any way exceed the federal government's constitutional powers. So very broad discretion to the agencies to determine, as you set your enforcement priorities, appreciate that the justification for that enforcement action, if it is in fact beyond the best read of the statute, and we'll come back to the Loper-Bright decision here in a minute, but that's providing pretty broad discretion to the agencies how they exercise their enforcement authority. So again, let's fast forward now to April 19 and the publication of the presidential memorandum regarding repeal of illegal regulations. And the directive that beginning on April 19th, agencies shall immediately take steps to effectuate the repeal of any regulation, a portion of a regulation, any guidance that clearly exceeds the agency's statutory authority or is otherwise unlawful. Makes sense. If we think that we've gone beyond our statutory authority, we should in fact repeal those regulations or restate those regulations. But this presidential memorandum went one step further and really caught folks' attention, because it directs that when you make these decisions to rescind regulations, you should do so without notice and comment on the basis of the good cause exception within the Administrative Procedures Act. And the justification there being is that it is never appropriate to have a regulation on the books that's unlawful. And so eliminating those regulations as quickly and as efficiently as possible is good cause not to go through the notice and comment period. The memorandum also directed agencies by May 19 to submit a written explanation why any regulation that they identified pursuant to the February order that was improper, why in fact it has not yet been repealed. So shall we say the clock has started for the agencies to begin taking action in response to identifying unlawful regulations. And in fact, the first agency you've seen out of the gate working on this is the Department of Treasury and IRS. April 15, kind of tax day, sort of nice there. They published some rescission of certain rules that had been published under different statutes. I think some were repeals of TARP regulations, We remember TARP, the troubled assets. I can't even remember what it stands for anymore, Kathy.
Really?
TARP, the Enron law, right?
Yeah,
Regulations, right? There's also some regulations under the Federal Financing Bank Act, as well as some partnership tax rules that have the agency has provided notice, not necessarily an opportunity for notice and comment, but a notice that those rules, those rescission of those regulations would be effective by mid-June. So that's the first federal agency that really has gone public with the action it intends to take in response to these directives from the president. Well, let's take a little deeper dive with regard to this directive to repeal regulations without notice and comment in reliance on the Administrative Procedure Act, and specifically how that's going to work with regard to CMS regulations, which we are particularly concerned. The APA provides that notice and comment rulemaking is not required in two specific circumstances. First, if the matter concerns agency management or personnel or other types of administrative activities, that there is no requirement there, as that there is no benefit to be gained from delaying action around notice and comment. The other exception is the good cause exception. And that is when the agency determines that it is either impractical, unnecessary, or contrary to the public interest to allow for the 60 days of commentary on a particular rule. Interestingly, we have a split in the federal circuit courts on how they are to review an agency's determination of good cause for no opportunity for notice and comment. You have some of the federal appeals courts saying, well, it's a de novo review. The courts look at that and decide on their own based on facts and circumstances whether in fact there was good cause, while other courts have said, no, it's the standard is the agency acting arbitrarily or capriciously. I think that sets up a really interesting what's going to happen next as we see repeals taken without notice and comment, and we have litigation over that, how that will work its way through the federal court systems. Because I anticipate, Kathy, we are looking at some litigation as there are efforts to repeal these types of regulations without notice or opportunity. The other piece of this to add in is the Richardson waiver, which dates back to 1971, long ago, where then Secretary Richardson established as policy under the APA that HHS in its rulemaking will never avoid notice and comment, even if the circumstances would apply under the APA, that they believe that public participation in the process will always be such that it is better to have some degree of notice and comment, and that good cause should only be used in emergency circumstances where it would be useless to have the public participate. It would not result in any change into the regulatory action to be taken. So that's how HHS had operated, including CMS as an HHS agency, how they had operated for decades. But on February 28th, HHS issued a new policy statement that rescinded the Richardson waiver. So this would have happened before the executive order that was directing the repeal under good cause. And now the policy of HHS is to follow the Administrative Procedures Act and only apply the good cause exception when appropriate in the circumstances under the APA requirements. And so that's how we're specifically for HHS, how they will move forward when they identify regulations for repeal under the unlawful standard. However, one of these fun facts that you can share on trivia night is that Medicare regulations are not subject to the APA. Did you know? There's actually a provision in the Social Security Act known as the Medicare APA that establishes the notice and comment requirements for Medicare and any rules that they create that impact either beneficiaries, providers, or payers. So anytime CMS is taking action that impacts the Medicare program, they have to allow for notice and comment. And there is no good cause exception in the Medicare APA. Appreciate it is not the CMS APA. It is only Medicare, so it doesn't apply to Medicaid or any of the other federal health care programs. Supreme Court has recognized the restrictiveness of the Medicare APA, where they had previously invalidated some crazy dish payment recalculations because the agency had failed to go through notice and comment. They had cited good cause, and the agency said, the Supreme Court said, yep, we're reading it, and we don't see good cause in the Medicare APA. And so CMSU acted inappropriately in those circumstances. And if you go back to that February 28, 2005 policy statement that rescinded the Richardson waiver, it didn't address the Medicare APA. And so we assume.
What about Medicare Advantage? Would that be included under the Medicare APA?
Yes.
Okay.
Yes, it's the provisions of the title. So,
all right.
Interesting going forward exactly how this is going to be handled, because can, in fact, CMS repeal any of its Medicare-related regulations when, in fact, without that notice and comment period, given the requirements under the Medicare APA. And again, there was no, we may have been in a different position if HHS had said, oh yeah, and we're also, this new policy, this waiver, the Richardson, the elimination of the Richardson waiver is going to apply to CMS Medicare regulations as well, but it was silent on that issue. So I think this is going to set up sort of an interesting, it's one of the most regulated industries, specifically tied to the Medicare program, how this is specifically going to move forward. We just don't know yet how Dr. Oz and his agency is going to handle this. I think the other interesting question here is, what does illegal mean in this context? And the executive order did not specifically define what constitutes an illegal regulation. Instead, there's direction to the agencies to prioritize in its evaluation of its own regulations the lawfulness under 10 specific Supreme Court decisions. And as you'll see, these are all relatively recent Supreme Court decisions. There's a list of 10. There's really only 5 of these that would apply in the healthcare context, starting, of course, with last summer's decision in Loper-Bright. That was the end of the Chevron deference. We'll come back to that in just a minute. The opinion in West Virginia versus EPA, which is the major questions doctrine, that it is not appropriate for an agency to regulate on a matter that is in fact a major question, and instead must have direct congressional action on which to base future regulations in that area. SEC versus Jarkowski, I can never pronounce these names. Jarkowski, okay. Which is the imposition of civil money penalties through administrative procedures, that in fact, administrative procedures are limited in fact to corrective action, and that it is inappropriate for an agency to impose civil money penalties, which of course is a form of punishment for the against an entity, and you have to then go through the formal court protections as opposed to administrative procedures. You have the Michigan versus EPA. We're getting closer. This is the consideration of when an agency is directed by Congress to issue regulations that are appropriate and necessary. And that's very common language that's used in statutory provisions. The agency must, as part of its analysis, consider the costs of the regulations as part of that equation. And then the other note is the Ohio versus EPA decision, also from last term, noting that a regulation is in fact arbitrary and capricious if the agency fails to respond to significant comments. And in that case, that the industry had made significant comments to a rule that the EPA had promulgated in publishing the final rule, proposed rule, excuse me. When it published the final rule, it did not respond to those comments. It kind of pretended it never saw that letter. And that was, Supreme Court determined that the failure to address those comments from the industry, in fact, meant that the agency was acting arbitrary and capriciously. And so that would be inappropriate. So that sort of is the context of what is an illegal regulation based on those kind of core Supreme Court decisions. But let's focus specifically on Loper-Bright, because this sets up, again, what I think is going to be really interesting as CMS moves forward. So if you're going to talk about Loper-Bright, you have to go back to Chevron deference. And yes, I'm pulling you back to last summer when this decision was issued in June. So do your best with us. As you know, agencies, of course, derive their authority to make or enforce regulations from statutes. And in case of CMS, that authority is derived from the very lengthy and detailed Social Security Act. And if you, as a regulated entity, don't like a regulation, your best defense is to file a lawsuit challenging the agency's authority, saying the agency either acted inconsistently or beyond the scope of the legislative provision. So Chevron, the Chevron decision from way back when, 1984, Kathy, something like that?
Yeah.
The court said, okay, well, sometimes Congress is not perfectly clear when it writes a statutory provision. And when the language of the statute is ambiguous, there are two or more reasonable interpretations of what Congress meant in the statute. We're going to defer, we the courts are going to defer to how the agency interprets the statute, provided that, of course, it's permissible. It's not totally off base. And so we move forward with that deference to agencies in those circumstances as they define the scope of their own authority through their interpretation of statutory provisions. And really, over again, decades, we had well over 18,000 decisions by federal district courts, courts of appeals, or even the Supreme Court, where the court concluded that, yes, the statute on which this regulation is based is ambiguous. And in fact, the interpretation that the agency is relying upon is a reasonable interpretation. And so we're going to defer to the agency. And in those cases, 90% of the time, the court said, yep, that's okay. The agency is acting within its responsibility. And we learned that in those cases where the language was unambiguous, the court said, no, that's not a reasonable interpretation on the part of the agency. Then in those cases, it was more frequent that the challenger would win as opposed to the agency. Not surprisingly, Chevron had many critics who believed that it unleashed the bureaucratic state and that it was empowering executive agencies far beyond what Congress had intended. And so there was a series of legal challenges to Chevron, which finally came to a head last summer with the Supreme Court's issuance of the decision in Loper-Bright Enterprises, or the end of Chevron deference. And writing the majority opinion, Chief Justice Roberts concluded that it is the role of courts and not agencies to interpret statutes, and that in fact a court may not and need not defer to an agency interpretation simply because the statute is ambiguous. And ambiguity instead is the responsibility of the courts, because every statute does have a best meaning, and it is the role of the courts to determine what best is, deploying its full interpretive toolkit. So there may be permissible interpretations. There may be 5 permissible interpretations, but it is the role of the courts to say, of those 5, which is the closest to what Congress intended. And so taking that deference away from the agencies, one would think we'd see contraction of regulatory action. And that's what folks, innumerable articles written following the Loper-Bright decision, that we're entering a new age of regulation, that this is finally allowing industry to be on equal terms with the regulator in reflection of what congressional intent, the people's will, shall we say, is. A key component of the Loper-Bright decision was the holding with regard to its retroactive effect. Again, remember, we had 18,000 decisions where a court deferred to an agency interpretation. Was the Loper-Bright Enterprises decision then going to be effectively unwinding all of that precedent? and thus striking all of those regulations. And the court said very clearly that, in fact, regulations previously upheld applying Chevron deference still remain in effect. So where does that lead us now? Because again, the presidential memorandum says an illegal regulation is one that is not consistent with Chevron, meaning the regulation is based on a permissible but not necessarily the best interpretation. Are we now, back over the net to the agencies to interpret which of their regulations were not based on the best interpretation, when we have Chief Justice Roberts telling us that's the role of the courts to decide this? So what we had anticipated to be sort of a free-for-all in litigation, challenging different regulations, now that there was no Chevron deference, will we even have that round of litigation, or are we instead going to have the agencies acting on their own to say, yeah, no, that's a bad interpretation of the statute. The statute, in fact, means this, and thus imposing its interpretation. So it's sort of like watching, the sausage be made, right, Kathy? And we're sort of in the middle right now, trying to figure out how is this all going to square out between the administration, the federal agencies, how the courts will interpret this, how industry raises its challenges. How does industry that believes a regulation is not consistent with the best interpretation of a statute? How do they bring a challenge in court? Do they go to the agency and encourage the agency to repeal this, especially since you don't have notice and comment, except potentially with regard to the Medicare regulation? So it will be an interesting process moving forward as we get rid of what we hopefully repeal what are determined to be unlawful regulations. As I said, that's only half the story. There are also efforts to repeal burdensome regulations, which is not a new game, right, Kathy? We've done this before.
Not. And this is where I think from a provider perspective, you really have a role to play. No matter what type of a provider you are, there are rules that are addressing what you're doing, and you need to take a look at what really could be eliminated. So let's kind of go back a little bit into history, go back to the prior Trump administration, 2019, towards the end of the administration. But again, there was a requirement under the Omnibus Burden Reduction final rule to identify and eliminate unnecessary, obsolete, or excessively burdensome regulations. The goal was to have savings of somewhere around $800 million a year, which is significantly less than what we're trying to achieve now. But some of the things that were addressed through the final rule in 2019, issues related to emergency preparedness. Rather than having to do an annual review of your emergency program, you could do it it could be biennial. Just an opportunity there, reduce costs. Hospitals were no longer required to have their medical staff attempt to secure autopsies in specific circumstances. Again, major burden, I guess that was identified as, so that was eliminated. The frequency of policy and procedure reviews was reduced for critical access hospitals. Ambulatory surgical centers were allowed to no longer have a written transfer agreement with a hospital. Home health agencies, the requirements related to verbal notifications were eliminated. You can see that there were a lot of things there, but it's hard to imagine how much these did in terms of actually reducing the overall administrative burden on providers.
Yeah. And Kathy, it's a sample. I mean, this is not everything that was in this.
You've got a link there that actually takes you to more, but
these aren't earth-shattering. Let's just say
exactly. That's the way to say it. These are the ones that are the top of the iceberg, as opposed, but these are not earth-shattering, nor is the rest of the list. So, But what we have now are,
Kathy, before you jump to that, there's one other interesting part of that final rule when it was published, is it was also the vehicle that was used to expand the conditions of participations for hospitals and critical access hospitals around quality assurance and performance improvement, and also introduced infection control and antibiotic stewardship programs. So it's kind of like an offset, right? Well, we got $880 million in savings to the industry by this reduced administrative burden. Oh, but by the way, here's a couple of $100 million more in burden because we changed the cops in those circumstances. So I guess the agency just can't resist, right?
well, and as a matter of fact, before we're done this morning, we're probably going to be talking about maybe those things that they added to us back in 2019 could go away or be less burdensome. So what we're looking at now is a number of opportunities to identify regulations that are burdensome or questionable. We have, first of all, the Department of Justice Anti-Competitive Regulations Task Force, with a requirement or an opportunity for the public to provide comment between now and May 27th. Essentially, the goal here was to identify state and federal laws and regulations that unnecessarily harm competition. And from a healthcare perspective, the task force is tasked with laws and regulations in healthcare markets too often discourage doctors and hospitals providing low-cost, high-quality healthcare and instead encourage overbilling and consolidation. These kinds of unnecessary anti-competitive regulations put affordable healthcare out of reach for millions of American families. This is an opportunity. This is bringing together predominantly interagency partners to identify these problems, these issues, but they are asking for public comment. And I think no one knows better what is causing the problems that, quote unquote, encourage overbilling and consolidation than the providers who are on the call today.
Yeah, this is one of the few opportunities if you've identified state laws and regulations that they want to hear about that as well.
Then we also have published in the Federal Register on April 11th, a request from the Office of Management and Budget looking to identify regulations that stifle American businesses and American ingenuity. Comments were intended to address the background of the rule, the reasons for the proposed rescission, with particular attention to regulations that are inconsistent with the statutory text or the Constitution, where costs exceed benefits, where regulation is outdated or unnecessary, or where regulation is burdening American businesses in unforeseen ways. Again, comments here are due on May 12th. You have a different email address in which our location to which you are providing comments on this. But taking it a step further, we have the request for information that both came out as a press release and as a I guess I would say a proposal in the inpatient proposed rule, rehab proposed rule, skilled nursing, inpatient psych, etc. All of the payment rules that were published for federal fiscal year 2026 included this request for information. And the idea here is that CMS is seeking input on approaches and opportunities to streamline regulations and reduce administrative burden on those who participate in the Medicare program. Where are there duplicative requirements? Where are there regulatory requirements that should be better streamlined? Just like the inpatient psych, rehab, skilled nursing, all the rules that came out on April 11th, comments on this are due on June 10th. However, you are submitting your comments to a different format, different mailbox, I guess I would say, than you do your Federal Register site for your actual comments on the proposed rule, the rates, the things like that, the quality measures. So again, an opportunity for you to submit comment. We're going to kind of walk through what they're asking you, and then we're going to maybe throw out some things for you to consider. Should these things be addressed? Are they burdensome? So let's start looking at some of the requirements that were, or the requested comments in the RFI and the proposed rules. Are there existing regulatory requirements that could be waived, modified, or streamlined to reduce administrative burden, but again, without compromising patient safety or the integrity of the Medicare program? Are there specific Medicare administrative processes, quality or data reporting requirements that could be automated or simplified to reduce administrative burden? Currently we have measures that we are reporting versus measures that are identified through the claim. Should more things be claim focused without additional information being submitted by providers? What changes can be made to simplify Medicare reporting and documentation, again, without affecting program integrity? What about the frequency or complexity of reporting for Medicare providers? Are there documentation or reporting requirements that are overly complex or redundant? And here we get a little bit more specific because they want to know which ones, and they want specific information on forms, on Office of Management and Budget Control numbers. So you do need to make sure you follow what they are asking. Don't just say, eliminate XYZ form and leave it at that. You do have to give some background and some context in that comment. Finally, on the duplicative requirements, what do you consider duplicative, either within the program or across healthcare programs? So are there things that you're having to do for Medicare that you're also being required to do for your state Medicaid program? Granted, we have the Medicare cost report where you have included Medicaid information, but are there other things that you're having to do for both Medicare and Medicaid? How can cross-agency collaboration be enhanced to reduce these duplicative efforts? And how can Medicare better align its requirements with best practices and industry standards without imposing additional requirements? That's where we start to get very concerned. What happens in terms of if we are starting to relieve certain burdens, but are they going to be adding additional burdens on you moving forward? So Martie, a few burdens without benefits.
Yeah, so let's do better than the omnibus burden reduction final rule. That's our goal. And Kathy and I spent a whole lot of time trying to identify, with a higher degree of specificity, rules, regulations, guidance that potentially should be brought to the attention of CMS as overly burdensome or not adding any benefit. And I think that becomes the test, is where are the regulations that impose a burden without a benefit? And where can we start, chipping away at the regulations? It is amazing, Kathy. I'm sure you've seen, we both saw this over the last 2 weeks. How many articles talk about the burden on healthcare providers and the hours and hours spent meeting regulatory requirements and the cost associated with it? And studies show that, 3 hours a day a doctor spends, fulfilling regulatory requirements. And those articles never cite what the requirements are. They'll talk about documentation requirements that don't get to a level of specificity, or they're talking about like prior authorization requirements.
My mind was going directly to prior authorization. That's not
a federal regular regulation,
exactly.
Right? So it's challenging to find, down to, as we say, chapter and verse of how do we start, unwinding this burden. So this is what we came up with, sort of working our way through what we say, Kathy, 75 years together of experience in the healthcare industry.
That is because we were both born in hospitals, so that's
right.
what it goes back to.
Exactly. And let's start with everybody's favorite, HIPAA, right? And what's the most recent provision added to HIPAA is the final rule on reproductive health care, and this idea of when can you, this kind of purpose-driven releases of information related to reproductive health. Those new requirements that became fully effective as of December 24th of last year is the squeeze worth the juice on these regulations, because they are, as we've talked to providers, that they've been developing processes and getting, interacting with agencies about completions of the required forms. It's an incredibly burdensome activity. And it is truly sort of rewriting a lot of the processes that have been established since 2003 with the advent of the HIPAA privacy rules. So is there a case to be made for the reversal of those rules? As you know, the HIPAA privacy rule has a whole lot of administrative requirements placed on providers for the purpose of protecting patient rights, informing patients of their rights. Again, is it worth the effort that we required of providers, such as this hand delivery of the notice of privacy practices or the posting of your notices of privacy practices? As we say, Kathy, the only one that benefits from that is Michael's, because they get to frame all of those notices the hospitals and other providers put up. And I mean, we're 2 decades into this now. Do we once again need, maybe it made sense in the early 2000s to provide these notices as they were new. But again, as it is necessary and appropriate now here in 2025 to continue with those requirements.
Well, and if you think about it from I'm just going to use the privacy side. When you think about, let's say, a credit card, once a year, I think you get something in the envelope that you toss, but you get something that, talks about how they're protecting you as the consumer, right? I mean, do we really have to give this as frequently, have it on the walls, have it everywhere else? Becomes one of these things. It's a question of why.
Yeah, is it enough to post it on the website? Since that, we're moving more and more to the website being the source of truth for organizations. Would that alone be sufficient? And it's the same notice for everybody, right? I'm getting the notice from this guy and this guy and this organization and this organization. It all says the same stuff.
And don't forget, I've translated it.
Yeah. Oh, exactly. I sometimes wonder, healthcare industry sort of has Stockholm syndrome, right? We've been so regulated for so long, we don't even know what they're doing to us any longer, and sort of having to be critical and thinking through this. But okay, all right. Let's talk about conditions of participation and certification, which certainly was a target in the Omnibus Burden Reduction Final Act. But there have been a lot of COPs added since 2019, including those that were added in 2019. But we have those in the outpatient rule last year. We had the new conditions of participation for hospitals around maternal health, which have significant staff training requirements, policy and procedure promulgation requirements built into there. Is this an opportunity, again, to revisit with a more friendly administration, shall we say, to providers at least in terms of deregulation?
The board or governing body having to identify who needs to go through the training.
Right, exactly. So is there opportunities there? We have the new hospital reporting requirements and respiratory conditions, which also went into effect in October, roughly. A lot of folks have complained the frequency of having to do that every 2 weeks, I believe, is just really not providing an accurate picture of what's going on in a community, and can those be pulled back? And then on this, those are new requirements, but in the world of ancient requirements that probably are time to go along the wayside are the physical plant requirements. Because you've got, I can't even explain this because I'm no expert in the life safety code, but you get into a lot of physical plant requirements that just are obsolete at this point in time, that require some significant investments. Accompanying our conditions of participation are the interpretive guidelines, which are the directives to state surveyors on how to apply the conditions of participation in specific circumstances. And those are all, as you know, contained in the appendices to the state operations manual. And including in that good old Appendix 5, which is the EMTALA interpretive guidelines. these guidelines, and this again is part of what the directive in these executive orders was. It's not just regulations promulgated through notice and comment, but it's the agency's sub-regulatory guidance. And particularly in the case of the cops, a lot of the devil is in the detail, which are these interpretive guidelines. Are there specific provisions in the interpretive guidelines that need to be revisited and reframed to eliminate burden? Because again, wisely so, I mean, if you're trying to develop a compliance strategy for an organization, you tend to take the conservative approach. Like, what is the conservative interpretation of what has been included in these interpretive guidelines? And so working in that protective mode, because of ambiguities left in the guidelines and the like, becomes incredibly burdensome. Kind of why we, go ahead, Kathy.
And don't we have COPs without interpretive guidelines?
Oh, yes. We have all the ones that were published in 2019, right? We still have no interpretive guide. How many times do I say this, Kathy? Still waiting. I feel like, Chevy Chase and Saturday Night Live, Franco is still dead, right? We still don't have interpretive guidelines.
But it seems like if we could have gone from 2019 to 2025 without getting interpretive guidelines, you wonder the purpose.
Exactly. Let's talk fraud and abuse and the unholy trinity of the anti-kickback statute, the Stark Law, and the prohibition on patient inducements. Again, the issue here, in large part, is because of the penalties associated. I mean, the first is a criminal statute, and the next two have significant fines and penalties associated with them. And so one tends to take a very conservative approach. And is there opportunity, particularly in the case of the anti-kickback statute, to actually broaden out the safe harbors and say this is okay to do this? Or in the case of Stark, broaden out and simplify the exceptions and say these financial arrangements are okay? Or the prohibition on patient inducements, which is just, can you give a patient a glass of water sometimes, right, seems to be the extreme application here. And what I find particularly frustrating is as CMS has developed alternative payment models, such as the Medicare Shared Savings Program, we have built into these MSSP regulations waivers of the fraud and abuse laws to ensure that the alternative payment model works appropriately. It seems we are at cross purposes at this point, right? That we have fraud and abuse laws, which really are to regulate a fee-for-service system and prevent overutilization, but they are creating a barrier to this all-important transition to value-based contracting
that allows us to save money, provide more quality care, and save money both to the provider and the Medicare program. We can eliminate these things, don't apply, but to the rest of the world they do.
Yeah, and I understand. I mean, this has been a topic of many conversations. It was a topic in the omnibus burden reduction rule of what can we do with the fraud and abuse laws, because the concern about program integrity. And if you give them an inch, they'll take a mile. Well, maybe they deserve a mile. And how these regulations develop that. Okay, off the soapbox to the next slide.
Okay, a burden without benefit. Let's continue this discussion. I remember way back, working in a hospital, and how we had forms, and you still have forms, although sometimes we're dealing with them in an electronic world. But literally, we used to have packages that identified if it was the blue package, it was for the Medicare patient. If it was the green package, it was for another payer group. But recognize that we have so much information that we are sharing with our Medicare patients. Things like the important message from Medicare, the advanced beneficiary notice of non-coverage, and the notice of non-coverage and detailed explanation of non-coverage, the MOON, the Medicare Outpatient Observation Notice, and our new, as of February 14th this year, Medicare Change of Status Notice. It seems to me that somewhere in the realm of the way things are going now, this could actually be provided through CMS as a part of the manual that the patients get every year that is fairly lengthy and published and mailed to their home. Give them more explanation in that and take that burden off of the providers. We've recently been dealing with the No Surprises Act. We've got to post things on our website. We've got to post things on our walls. We've got to give copies to patients. We've actually even got to provide certain estimates and things like that in whatever manner and format the patient wants. And we're still working off of, for the most part, interim rules, not even final rules for the work that we're doing there. But again, it's the whole issue of the burden on the provider to provide all the forms, much less provide the estimate. And then with the Medicare cost report, are there parts of the cost report that are really extraneous? And maybe we should be looking at the cost report from the perspective of for the acute care hospital paid under the Inpatient Prospective Payment System versus the cost report for the critical access hospitals, et cetera, but having a different focus and identifying what information, what forms are actually needed to establish cost, not to establish all of this extraneous information. And Martie, 1557?
Yep, 2 regulations promulgated about this time last year by the Biden administration, Section 1557 of the Affordable Care Act, the anti-discrimination regulations. There is the regulation says you can't do this, and then there are all the administrative requirements put in place to ensure you don't do that. Are there opportunities to reduce those administrative requirements? Similarly, Section 504 of the Rehabilitation Act creates these new standards for accessible medical diagnostic equipment, scales and tables, for example, as well as the digital accessibility, what you do with your website. Are those imposing burden where it's not worth the potential added benefit to patients included there?
And on 1557, very quickly, is not that we're saying, that we should discriminate. What we're saying is now I have a requirement to give you a form saying that I don't.
Right. Or I do annual training for all of my staff.
Exactly.
All of those. The hours we spend training staff. Anyway, other burdens without benefit, of course, quality reporting programs have been paid a great deal of attention in this space. Are there measures that don't actually provide meaningful or actionable information? Are there duplicative or inconsistent definitions of terms or reporting methodologies that need to be examined? I think, Kathy, we've gone from, I always talk, my bell curve, right? There's simplistic, complex, and simple. And we've been living at the top of the bell curve in complex for a long time. Right. When it comes to quality reporting. Do we now have opportunities to simplify and make it very straightforward and have meaningful information that patients can take action on? I really can't determine what the best hospital is by looking across 45 different measures. Right. Get me to mortality. Okay. Get me to those core measures. Certainly the meaningful use program and the reporting requirements under that are opportunities to reduce burden, as are the hospital and skilled nursing facility value-based purchasing programs. That again sets requirements into those programs, imposing burden. If there is anyone that likes the merit-based incentive payment program, please let me know, because I don't think anyone likes MIPS. It's not, again, the promise of MIPS was to vary payment based on the quality of services. And in fact, what it's created is incredible data gathering and reporting obligations, including the meaningful use requirements of MIPS as well. The incident to requirements, direct supervision and all of its nightmares is now at the time finally to say virtual supervision is just fine. Right. And as long as there's an opportunity to contact the beneficiary. The requirements for billing virtual services. So here, care management, remote patient monitoring, general behavioral health integration, those services. Let's revisit the requirement that we have to have consent from the patient for those services, the specific consent. Similarly, the requirement that there be an established patient relationship to deliver these services, which have proven to be burdensome, and compliance considerations are actually inhibiting the adoption of these types of services. And then, of course, the wonderful can of worms known as telehealth. Yes, we've got to work within statutory provisions, and of course, we can't repeal the statutes through this process. We can change the regulations, but we can't change the statutes. And the statute defines coverage for telehealth services under the Medicare program. But let's look at other issues like teleprescribing for controlled substances. What's the list of telehealth approved services? What are the limits on audio only services? All of that, trying to kind of free up the opportunity for telehealth. So there we go.
Let me just say, I know we're getting close to our time, but let me just say, Martie said this is when you're dealing something that is statutory, this isn't the process for that. So don't start thinking sniff 3-day window, a 3-day prior stay, things like that. That's statutory. That's not something, I mean, I think a lot of people, their mind immediately goes there, but that is not something to comment on in this particular case.
Yeah, Kathy, the other thought I just had when you said 3-day rule, I was like, well, but we had the waiver during COVID. Oh, yeah, wait, we had the waiver during COVID. Maybe we need to go back to that.
The 3-day prior stay, right.
But there were a whole set of regulatory waivers during COVID. Yes. Maybe it's time to go back and look at those and say, hey, CMS, we survived COVID without having these regs in place. Maybe it's time to repeal those as well. I should have thought of that. Yeah, I should have thought of that when we were doing the slides. Oh, well. Finally, very quickly, just to wrap up, what's going on in Washington? As I said, they're back from their recess. Where it stood before they left is they had a budget resolution. They had direction on how to formulate this reconciliation bill, the targets that they have in place, and now they get down to the hard work. Where we stand now is this process of the House and Senate. There we go. The House and Senate doing the markup, i.e. actually drafting the text of the legislation. There's a whole lot, at least if you believe what you read in The Hill and Politico, a whole lot of behind the scenes negotiations going on as folks are staking out their positions. Probably the central piece here is the current baseline debate, because this will be determinative of how much tax cut we can get without deficit spending. The idea being that the 2017 tax cuts, even though they are set to expire this year, that we assume that's baseline, so we don't have to pay for the extension of those tax cuts. And so we don't have to cut other federal spending for the tax cuts. That's going to be the debate, is resolving that. Because if you're going to, it's determinative what the tax cuts are going to be, is how much are we willing to deficit finance, and how do we define what is deficit financing. The goal still is to have the bill ready to go by Memorial Day and to the president's desk. So we will see how quickly that moves forward. What we are looking at very closely, of course, is what's going to happen in Energy and Commerce with Medicare and Medicaid. Because if you got to cut $880 billion, that's their target in the budget resolution, what do you do? You've got them saying, no, we're not going to, this is not going to be a health care bill. But at the same time, you've got other groups saying that we don't like provider taxes for the states, and we wanted to attack those because that expands spending. So it's going to be a very interesting month watching what's going on and going forward here. To that end, our next regulatory roundup webinar will focus on that process. As we say, there'll be something to talk about what's going on. As Kathy wanted to credit Monty Reep with the title for our next HCRR, but we are certain there'll be plenty to talk about then. Of course, please subscribe to our newsletter where we're trying to keep you as updated as possible on these recent developments and the like. So thank you again for joining us today. And Jennifer, back to you.
Thank you.
Thanks to our presenters, Martie and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.